Okay, guys. So welcome to part 2 of fluid resuscitation in pediatrics. So we have spoken about the manner in which the kiddies lose fluids. So we have said vomiting. It can be vomiting alone. It can just be diarrhea alone. It can be diarrhea and vomiting. It can also be excessive sweating. Especially in hot countries, countries with their very hot weather. And we have spoken about the fluid compartments, that when you are just dehydrated, you have just lost extravascular fluid. So someone who has lost extravascular fluid, or fluid from the extravascular compartment, and we said extravascular is interstitial and intracellular. So if we have just lost extravascular fluid, or you have just lost fluid from the extravascular compartments, you will be dehydrated, but your intravascular volume will be okay. So which means you will have a normal BP and a normal pulse, right? But the minute you start to lose intravascular fluid from the fluid loss that the kid is experiencing, with undergoing, then you start now to lose blood volume, and your blood pressure will drop, your pulse will go up until it goes down, until it's no more. So basically we are talking about shock here. Very important to understand. And we've said that so now let's talk briefly about the possible when resuscitating. Like I always say, when you are resuscitating, the cause is not important. The cause of whatever is not important. The job is to resuscitate. When a child comes in, they say it's been vomiting, having diarrhea, the cause of the diarrhea, the cause of the vomiting, or the cause of the two is not important. As long as the child is unstable, you go on and resuscitate the patient. So if the child is having these, you want to check for stability. How stable is this kidney? If unstable, or if they are stable, so unstable would be shock here. That's an unstable patient. Or severe forms, or just severe dehydration. But if the child has got dehydration and you think it's mild, or you think there's no dehydration, not every kid that comes in with diarrhea, vomiting, and they have dehydration. Some will not have dehydration, no dehy. So which means this kidney might have lost a bit of fluid, but has not gotten to a point where they are dehydrated. Or you can have them or you can have them not dehydrated, or undehydrated, or not dehydrated, or dehydrated, either mild, moderate, or severe. The biggest problem and it's a skill that I'm also still learning. It's a skill that I'm still learning. Calculating the fluid is not the biggest issue. It is the number one problem. It is the number two, sorry. The number one issue, the number one problem here is proper assessment. Proper assessment of the dehydration or the hydration status. That's the number one problem. That's the biggest problem. And it's a skill that even experienced doctors are still struggling with. It needs you to have been working with them to really wrap your finger around this. So the biggest problem is how to properly assess the level of dehydration in a kiddie, because when you overestimate, the kiddie becomes fluid overloaded, and when you underestimate, you still lose the kiddie, or they just don't get better. It's very difficult, right? It's not easy. When I get a kiddie, it has happened a couple of times. When I get a kiddie in especially when I was in the district, when I get a kid in casualty, the nurses, in OPD would be busy seeing a patient, and then they just say, there's a patient in red room. When a nurse says, the triage there when I was working is one of the best. So when the sisters come rushing to your consultation room, they say, Doc, we've got a patient in red room. You have to stop what you're doing and go to red room. Most of the time, the child was dehydrated. Where I was for 3 months, it was a child who was dehydrated. About 80% of the times, it was a kid who was dehydrated. So you come in there, you assess them, and then you quickly get a line. So when you have a kid, okay, these are the, I need to create some space. Okay. So what you want for this one who is in shock, you want to bolus this one. You want to bolus this one, this kidney. And when I say bolus, I mean that you want to take the fluid that is used is normal saline. So you take depending on their weight and age. So you want to, after you have gotten a line, you want to, because this one is not going to be able to drink, because if it's in shock, likely that they are very lethargic, likely that they have lost consciousness, likely that they are just lying there and maybe even unresponsive. So they cannot, so oral fluids will not work on this one. They need a bolus. The bolus is meant to rapidly increase the depleted intravascular volume, because we said that when you are in shock, you have depleted your intravascular, so you have lost a lot of intravascular fluid. Yes, you started there, but now this one is not gonna kill dehydration. What is gonna kill you with dehydration is when you get to the shock. So once you get to the shock, you want to take them, once you remove them from the shock, you will take them back to dehydration, and then from there you take them to a state of euvolemia, right? Because you first lose interstitial fluid and intracellular fluid, and then now when the dehydration becomes very worse, you start now to lose your intravascular as well. So this is so not everyone who's dehydrated is in shock. That's why you don't bolus everyone. So not everyone who is dehydrated dehydrated, has got severe dehydration, or is in shock. That's why we don't bolus everyone, because once you bolus someone who doesn't need a bolus, they will be fluid overloaded. So these ones have lost a lot of intravascular fluid. So to push that blood pressure up, to drop that pulse to normal, we need to give them a bolus. And the fluid of choice is normal saline. Yes, there has been a mistake that has been made a couple of times. You are still gonna see it, where people bolus with half DD. Half DD is not a fluid of choice for bolus. Half DD is for maintenance. It's a maintenance fluid. For a shocked kidney, you give normal saline. We are going to talk about how much you give and all of that. So you literally take a 20 ml syringe or whatever, 10 ml, whatever fluid, whatever amount, and you push it there into their veins directly. And you are gonna see a response in like 5 to 10 minutes. You are gonna see a response. If you don't see a response, you are gonna have to repeat it. So it's normal saline, it's not half DD. And then once you have taken, and then after giving them that bolus, you take them out of shock, because you want to take them out of shock. That's why you are giving the bolus. Once they are out of shock, now you start now to calculate their half DD that you're gonna be giving. As they will be going to the ward, they will continue with the half DD, and you will calculate a replacement fluid. And if there is research in terms of the fluid, let me just mention that as well. In terms of fluids in kidney, they talk about resus, they talk about the replacement, they talk about maintenance. So these, and then so resus fluids, for this kind of situation, you give your bolus. For replacement, you can, and for replacement and maintenance, you can use also, and you can also use half DD, but don't use half DD for bolusing. Okay. So now, so for these ones, you've put your IV line. So let me talk about this as well. There are 3 ways that I'm aware of that you can give a kidney fluid. So one is the way or the method in which you give fluid to the kidney depends on the dehydration, the level of dehydration. So one, there's nothing wrong giving a kidney oral fluid, meaning oral. This is for someone who's got mild dehydration, who has got vomiting and diarrhea, but no signs of I'm saying oral fluids for a kidney who has a history of vomiting or diarrhea or all of that, but with no signs of dehydration. They benefit from oral. The nice thing about oral is that you can never overhydrate from oral. The kidney will refuse when they get to a point whereby their thirst center is no longer activated. So there's nothing wrong as long as this method is appropriate for the level of dehydration. So this is for someone who's not dehydrated and for someone who's got mild, moderate dehydration. If this is not appropriate, then one thing that you can also give NG cube. You can give via an NG cube. Number 3, IV line. Number 4, intraosseous. This is why in many places a kidney that dies from diarrhea and vomiting it becomes a very big thing, because you have so many options there. If you can't put them on oral, you've got a choice of an NG tube. If you can't do an NG tube, you have to try a line. If you can't, there's an intraosseous, which almost always works as long as the child still has got, as long as the age is appropriate. So yeah, so those are the methods in which you can administer fluids to a kiddie. So now let's talk about, so I said the number one problem is proper assessment. And because the method, I don't even think there's a second problem. I think the biggest problem is proper assessment. And it's a skill that all of us still needs to learn. It's a skill that it's not easy to acquire, but it's something that's very important that we need to learn. Because based on your assessment of the hydration status or the level of dehydration, that will determine, one, the method of administering the fluid. The method. If the assessment is not accurate, it's likely that a wrong method will be instituted. For instance, a child is in shock, but you didn't pick it up that the child is in shock, and then you say, let's do oral fluids. That child is gonna demise. So that's what I'm saying. Proper assessment is gonna lead you to what type of method you have to institute. Number two, a proper assessment will tell you if you admit or you discharge the kiddie. Number three, a proper assessment will tell you the type of fluid to give. So, if there's one thing that we need to learn, the calculation of fluid is not the biggest issue, but the assessment is. The assessment is. And where I was doing my in the district where I was doing my 3 months of district exposure, we had this thing of 4-hourly hydration checks. So when you do, I mean, in some places it's even 2-hourly hydration checks, and it's a job of an intern to do that, and the doctor who works in that ward, but it's mostly a job of the intern. The nice thing about, one of the problems is that in medicine, when you are a lazy person, you easily get into trouble. Like, for instance, if I'm in the hospital, I wouldn't mind doing a 2-hourly hydration checks for the first 6 hours. Because when you do a 2-hourly hydration check, you are able to see if the kid is improving, or if you underestimated the dehydration, now the child is just worsening, or if you overestimated, now the child is getting into a state of fluid overload. So we are going to talk about the signs and symptoms of fluid overload as well, and you can always adjust. So if you go regularly to check, you can always adjust, but the 2-hourly is not always possible because of how busy doctors are. But so the least that we can do is 4-hourly. But if there's manpower, then you can always do 4-hourly. Okay, so guys, let's meet again in part 3 of this. Thank you.